invite and introduce Dr. Matt Martinez. Matt, welcome. Dr. Martinez joins us from Atlantic Health Morristown Medical Center. He's the medical director of sports cardiology. He's the medical director of the hypertrophic cardiomyopathy program. Um, Dr. Martinez had his medical school from Mayo Clinic College of Medicine, where he pursued his internal medicine, cardiovascular fellowship, and also he was an assistant professor of medicine in 2004 when actually I had the fortitude of having to meet him when he was there as a staff. So we know each other ever since then, and we have been great colleagues and friends. I've seen his rise to stardom in the field of sports cardiology. Uh, Dr. Martinez currently is well represented all across in major teams, NBA, NFL, NHL, USHL, so on and so forth. Uh, to his credit, he is one of the thought leaders and the main leaders in sports cardiology, and he continues to have a significant presence in scientific societies where he has been in not only scientific program committees, but also in scientific speaking assignments, but also to shape the guidelines in the AHA and the ACC. He has also been very active in SCMR and AHA. He has um, interest not only in sports cardiology as his clinical part, but he is an imager. He is practices echocardiography and multimodality imaging, specifically cardiac MRI. He's very well published with over 130 manuscripts, and I saw in his CV that he currently also has some interest in AI. Has been dabbling into some of the grants in the AI. Uh, and we are looking forward to collaborating on this field. With that, today we are having a feast. Matt, welcome once more, and thanks for joining us. And the floor is all yours.
Well, thank you for the invitation. And Partho, always fun to talk with you and see all the work you're doing. And it's amazing how many folks we all work together that are all now expanding. I heard from Kim Skelding today, who is a competing meeting. She and I, she was my interventional fellow back then. So we know each other a long time as well. So I'm excited to talk to you about this topic. Let me share my screen. And yes, I even threw in a slide about AI because I knew you would be here. And this is an important advancement, I think, in all of cardiology, but certainly in sports cardiology. And I'm going to focus today on sports cardiology, but I can't help but bring in at least a little bit of hypertrophic cardiomyopathy, tell you about where the field started and where we're ended up now with our recent set of guidelines. And you heard about this already. These are my disclosures. They're mostly free work, as much as it may look glamorous. It is a lot of phone calls and a lot of follow-up, but it is the fun part as we have really evolved a field that 15 years ago didn't even exist. And care of the athlete is like everything else we do in cardiovascular care. It's a team approach. So it's the athlete, of course, that would be the patient, and the sports medicine doctor, along with now the sports cardiologist and all of the groups that go with that in a multidisciplinary athletic care team to not only evaluate, but to manage the athletes for risk of sudden death and hopefully make sure that they can stay on the field. Let me see if I can get that out of the way. Oh, sorry. So the fundamental core competencies we wrote about in 2017 as a group, we needed to create this so that people knew who we were talking about. And it's evaluating patients with symptoms. They're highly active individuals with cardiovascular disease. On the bottom, it's management of those with known disease. And then, of course, differentiating between what is a pathologic finding and what is just EICR, or exercise-induced cardiovascular remodeling, what we used to term the athlete heart. And we're going to go through all that. Collaboration, of course, for cardiovascular screening for the athletes from a safety standpoint. And I'm going to show you how we do it and the pitfalls and some of the challenges that go with managing that sort of screening program. And it really started years ago. And the NBA was the first league in North America to begin standardized cardiac screening. This was a newspaper article written in 2006 describing this five person panel, Barry Marin, one of them, and four more on that. And it was somewhat in response to changes in the NBA, but also some of the things that were happening across the pond. And at that time, FIFA, right at that same time, started a pilot after Mark Vivian Foe, who had HCM, and Nicolas Ferrer died suddenly from dilated cardiomyopathy on the field, leaving them saying, what did we miss? What were the challenges that got us to this scenario, and how can we prevent this from happening again? So how do we identify those who are at highest risk without just throwing the baby out with the bathwater? How do we tell everybody to go away? How do we tell everybody that they can't play without eliminating everybody all at the same time? And at that point, our understanding of sudden death looked like what you were taught, that over the last 40 years from 1980 to just pre-2006, this is what we looked like. And it was data from Barry Marin and others where they had multiple updates since then, 2007, 2009, and 2016, over 2,400 included, and over 840 deaths were confirmed in this database. But the data remained the same because the message remained the same because the data was largely unchanged. They kept reviewing the same data and, of course, coming up with the same conclusions that HCM was the dominant reason folks were dying suddenly. Over a third of the entire population, maybe up to 45% if you include LVH, were the reasons folks died suddenly. But contemporary estimates of sudden cardiac death, they challenge that. This is data from the NCAA, UK, the military, and FIFA, indicating that HCM is important, but cardiomyopathies are a much smaller piece of that pie in the modern era. In fact, the majority is sudden unexplained death, or SUD. So this is important for the fellows who are listening because there's much work to be done in this field that we still don't fully understand risk for sudden death. But for the rest of us to remember that at least about a third, we're never going to identify who it is or what the culprit was for risk for sudden death. We know that some groups are at higher risk than others. So if you look at men versus women, you're going to see that there's a dramatic increase in male sudden death risk compared to women, 4 times the female counterparts, and nearly 9 out of 10 deaths are going to occur in men. So this is important because when we're talking about screening athletes and we have findings in those that are at risk, men carry a much different risk than do women. We know that Black athletes across the board in nearly every study have had a higher risk compared to white athletes. We don't think it's genetic. We don't think it's who they are. It's probably social determinants of health, where they came from and some of the early strategies for that group. But it's important not to overestimate their risk because we're going to disqualify a lot of young Black athletes who have a career ahead of them before anything in terms of risk occurs. We know that across the board, there are some sports that are at higher risk than others. And this is one example. There are multiple publications looking at this, but men's basketball, men's soccer, and men's football seem to be at the highest risk of them all, and they generally stay that way, although we quote about a 1 in 50,000 to 1 in 100,000 overall risk. Some groups are at much higher risk than others. So when we think about sport, there are some institutions who say these are the individuals we need to screen more vigorously if they play American style football, men playing basketball, or men playing soccer. And then the division matters as well. If they're playing Division I basketball at Rutgers, their risk of sudden death is considerably higher than if they're playing at a Division III school, even if it's the same sport and they look the same. So the type of sport, where they play, what the resources are to maintain safety in those athletes, all goes into that potential risk. So most everywhere in the world evaluates athletes using the same strategies you use for your high school, collegiate, pro sports. We do a cardiovascular screening, PPE. We do a comprehensive personal and family history and a physical exam using the AHA 14 point, recognizing there are challenges with this in terms of who asks the questions, who interprets the questions, how quickly you have to do it, and how vested both the interviewer and the interviewee are in getting those questions right. So additional testing is often employed. Usually ECG, we're going to talk about that, and echocardiograms are often utilized as additional support to look for those who may be at added risk. And then MRI and CT and comprehensive stress testing are usually added only in those who have an abnormal finding. It's pretty unusual to do that uniformly in every athlete every year. So these are the strategies that you can see both here and abroad for the elite level athlete. And we all do it just a little bit different, although we are certainly coalescing around some clear messages that combines in general are going away. We don't know the value of this from a cardiac screening, but a single test is not going to be sufficient. History and physical is important, and boy, the ECG has taken on storm. Everybody uses at least an electrocardiogram to evaluate athletes, but they sometimes do it annually, sometimes they do it every 2 years. And then echoes are often added on top of that, either as a one-time screen or as an annual evaluation like we do in the NBA. We used to do a stress echo every single year in the NBA. Now it's actually only the first year athletes, whether they went to the combine or not. If you're a first year NBA player, we screen you and then we stop looking after that. And it's because we know we're looking for added features, added value in evaluating player health and safety so that we can get ahead of it like we've never been able to do before. So if you go all the way back to when they first described cardiovascular pre-participation screening, 1996, if you can believe it, they even knew then that this is the best available and most practical approach to screening populations of competitive sports, but it simply lacks the intrinsic capability to reliably identify potentially lethal cardiovascular abnormalities. So even then, they knew they needed more, but it was too complicated and too cumbersome, and there wasn't enough strict criteria to sort it out. So here are some examples. I'm going to give you a minute to look through that, of course, numbered in your own head. Look at these ECGs and try and get a sense for which one you might call abnormal and pull that athlete to get additional testing. So if you look at number 4, this is massive voltage, often off the top of the paper, but these are typical. About 80% of athletes will have that high voltage with a normal T wave after it. This is a typical athlete's ECG, whether regardless of the sport, we see it more in men, more in endurance athletes. This is another J point elevation, often called by normal ECG standards as pericarditis or ischemia, consider a early MI, but a normal finding. Again, over 80% of athletes, more men than in women, but we see it across the board, very common. Here's a T wave inversion that's in V1, V2, and V3, both men and women, common, not a concern as long as it doesn't go past V4 and there's no dip and then rise again. This is a normal athlete repolarization pattern, what we used to call the black repolarization pattern. And the new international criteria, we're going to remove that because we see it in both white athletes less commonly than black athletes, but we see it in both. And we didn't really like the connotation that there were some individuals who should be called out compared to others. There's some risk with that, which we'll talk about. Now, this is clearly abnormal. T-wave inversions in 2, 3, and AVF, certainly 2 and F, these are pathologic until proven otherwise. And even this is changing. If there's not an ST depression associated with it, this may be a normal finding in the majority of athletes. Expect that to change going forward in the next set of criteria. So what you're looking for is T-wave inversions like this, diffusely in high lateral leads and beyond V4 into V5 and V6, where there's a flat ST segment and then T-wave inversions, or more worrisome ST depressions plus T-wave inversions. Maybe you see Q waves, whether it's inferior or lateral. These are pathologic when they include more than 25% Q compared to the upper S wave on top of it. So, or R wave, I'm sorry, on top of it. So that pattern matters depending on how deep that Q wave is, and then the left bundle branch block is always pathologic. Either dilated cardiomyopathy, HCM, may actually mimic WPW depending on what the pattern looks like. So there's a clear distinction between what's an abnormal ECG and what's a physiologic adaptation. Even though they are going to be called by regular ECG machines as abnormal, this is an opportunity for us to sort through that. And over the last 15 or 18 years, we've gotten better. And the ECG criteria for false positives in athletes has gone down, 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 and in the right hands is about 1 or 2%. So this is where we stand now, the 2017 recommendations, where we separated into normal findings in green, clearly abnormal findings in red, and then that group in the middle where if you have more than one, it's concerning enough to move into the pathologic category. That's going to change a bit going forward for 2026 when we finally get that data published. But suffice it to say, this has served us well in terms of reducing the number of false positives in those who are elite in evaluating athletes using this criteria. But it does depend on who you're talking about. Is it HCM? Is it anomalous coronary? Or is it Brugada? The specificity can change depending on the disease we're talking about. And then even if you find it, why do we care? Is there an impact by identifying these findings using ECG? So here's a study that'll almost certainly never be duplicated. It's the largest of its kind. Over 11,000 young soccer players overseas between 15 and 17, a comprehensive assessment, mandatory H&P, an ECG and an echo, and they followed them for 20 years. They found 2% with congenital abnormalities and valve disease, about 0.4% with the findings that could be associated with sudden cardiac arrest. Of them, 23 died. So of the 40 plus, 23 died, 8 from cardiac causes and 7 due to cardiomyopathy. So why am I telling you this? Because 6 of them were not identified by screening. So they were missed. And here what they look like. Here's all 8 deaths in that small population overall. And you can see that their initial screen was normal, and then 2 blinded readers on the end there, reviewer 1, reviewer 2, after they had cardiac arrest, confirmed that everything was normal. But what I found interesting is look at the time between the screening and the death. So one is a couple of months, up to over a decade in 2 of them, reminding us that maybe this doesn't mean it doesn't work at all. It means that a single ECG for a 15 and 16-year-old is not enough for clearance of this group, and more has to be done. And what the criteria has done is that it improved our ability to make diagnoses. We said earlier, HCM patterns versus physiologic patterns, but we've never been able to improve survival using ECG screening. But what I worry about is there a potential risk for harm? So if you look at the data in total, this is where all that came from, over 5,000 NCAA athletes. You'll see right away, almost 3/4 of them were from white athletes and most of them were men. And in that overall criteria, again, about 1 to 2% false positive criteria. If you look at that large study we just talked about, 11,000 soccer players, again, they report about a 1.8 or 1.5% overall false positive rate. But when you separate white athletes from black athletes, that number jumps considerably, over double the likelihood of a false positive ECG in black athletes compared to white. So this makes me nervous when we're talking about data that we're applying to both men and women, that is the majority of which is based on white men, and applying this to black athletes. So I looked at what was already published, and this is a good study. That's from Dave Engel and colleagues before I joined the NBA in 2018. And they looked at all of their athletes, over 519 of them, and they applied the international criteria, the standard of the time. And you can see they reported 15.8% false positives in African American, self-described African American athletes, compared to 11.5 in white athletes. But they didn't compare it to the whole group. They compared it to the individual session. So within the African American or the white population, that's where those numbers came from. But if you do it in total, an NBA is mostly black athletes, almost 80%. So the false positive rate in those who are white athletes compared to the entire group is just what we saw in the international criteria. It fits about 2%. How about the black athletes? Over 12%. Yikes, 6 times higher likelihood for false positives. So consider the unintended consequences if you don't have the ability to get an ECG, an echo, a sports cardiology consult, and an MRI all within 24 hours. When you look at applications in diverse populations, like these professional sports here, there's a real potential for harm. Or worse yet, what if you apply it in high school athletes, which is what we're about to see in Florida, where the Second Chance Act requires an ECG in all high school athletes? There's 500,000 high school athletes in Florida. If the false positive rate is even 1%, you're already starting to see the risk for false positives. And a lot of them are black athletes, so it's going to be over tenfold. So what we've written about, and this paper is about to come out, we hope, looking at pre-participation physicals. We know they're happening. So if you're going to do it, a comprehensive physical and a screening ECG, make sure that you developed as a part of a important screening program where you already have the ability to get access. I'm sure you do. We do too. When there's a false positive or any abnormality, they call me and we can usually get them in within 24 or 48 hours to try and accommodate the athletes sooner so that we're not keeping them off the field compared to compared to other scenarios where it can take 3 to 6 months to find a pediatric cardiologist. And then worse yet, a pediatric cardiologist with sports cardiology training and expertise who is willing to say, yep, this is normal or this is abnormal. We're going to risk stratify you. So this is where we are now, and I hope that we're going to learn from some of the experience here with AI. So detecting HCM with AI ECG is growing, and Partho and I have talked about this a lot. There's an opportunity to try and figure out a best practice for this. There's already some published data you can see here and just a handful of studies looking at HCM. But once we refine this criteria and I start to understand it a lot better than I do right now, as I try and dig into this, we need to figure out a good way to employ AI so that we can study huge populations, reduce the false positive rate, and then be able to figure out a process to handle that false positive group. Because just an abnormal ECG is not going to be enough, of course, to make a diagnosis of HCM. You still need cardiac imaging. So cardiac imaging plays an important role in athletes as well. And most of it is in what we see here in both echo and in MRI. But there's overlap between what you get from an EKG evaluation and what you get from an echo. I would argue both are important. EKGs show you things echoes will not be able to find. And echo, of course, identifies things like anomalous coronary arteries and dilated roots and bicuspid aortic valve, which may not be at higher risk, a dilated aorta or a bicuspid valve immediately, but they do have impact on player health and safety. And there's variation about what a normal athlete echo looks like compared to a pathologic finding. There's overlap just like there is in EKGs. So we know that the chambers in athletes can dilate, both the left and the right chamber. They can also thicken physiologically, where it's concentric or eccentric. The left chamber can dilate just alone with or without LVH. And of course, the right chamber does the same, where it can dilate usually equal to what you get on the LV side. But what you're trying to figure out is the gray zone. What's the overlap between a mildly hypertrophied ventricle and a significantly dilated hypertrophy ventricle like an HCM? So is it a DCM or is it physiologic? Is it HCM or is it hypertensive heart disease or is it right ventricular cardiomyopathy? So here's what the data looks like to give you an idea of how much overlap we see. This is old data from Policia from 1999. You can see 15% of elite level athletes that he looked at, over 1,000 athletes in this study, 14% of them fell into the dilated cardiomyopathy range. In more contemporary data, we looked at this in the NBA. Worse, a third will be over 60 millimeters in terms of LV chamber size, and it does seem to correlate with body size. So the taller the athlete, the larger the ventricle, no surprise, but they do seem to preserve their LV function. If you're a cyclist, it's worse yet. About half will have a ventricle of 60 millimeters or larger, and most of them will have a normal LV, but different than what we saw in the LV, in the NBA data, about 10% will have a low normal or just under LV, under 50% LV function, never below 45, but still we can see a ventricle at 47, 48% when we quantify it more completely. Most of the time, the ejection fraction is normal, but if you find one that's reduced, this is a physiologic change. So now we now have a lot of data on this, more so than we've ever had before. Depends on the sport, depends on where you're from. But dilated ventricle, left ventricle is a big part of the athletes, but we don't have an absolute cutoff. You have to correlate this to what the athlete is, what sport they play, where they're from. So using an absolute cutoff value for size is really not recommended. You really should be indexing this to body size when available. Use published gender and sport specific normative data. So LVH is a little bit different. So this is data from the NFL Combine. About 10% are going to have wall thickness above 13 millimeters. If you use ASC criteria, it's quite a bit higher than that. This is data from Aaron Bagish and Tim Churchill looking at wall thickness in U.S. soccer athletes, and you can see a third of the women were above ASC cutoffs, and over 40% of the men were above ASC cutoff as defined by LVH. But few of them were into that gray zone of 14, 15, 13, 14 that we often think about. And then look at the women. Nobody was above 12 millimeters. So although we call it gray zone at 13, 14, we don't see it. So if you see a woman who has wall thickness of 14 millimeters, no matter what sport they play, this is probably pathologic compared to what we would say in a man, where we would say it's possibly physiologic. So sorting through that is important, and that's where your sports cardiologist can help you. We see the same thing in the NBA. So for the athlete echo, there's still some good cutoffs we can use for thickness. Unlike dilated, but for thickness, 15 millimeters or thinner is still considered normal, but make sure that you add in whether or not the ventricle is dilated or normal size. A smaller ventricle is typically pathologic in an athlete and not usually seen. And then, of course, incorporate whether or not they're a man or a woman as to whether or not this is physiologic or not. So unlike in dilated, you can use cutoff values for LV wall thickness. 15 millimeters or thicker is pathologic. 13, 14 depends. Most of the time it's going to be gray zone. And then you, of course, under 11 or 12 is generally considered physiologic and normal, non-pathologic. But even that's changing. More to come on that. The RV can fulfill minor criteria as well. The RV can dilate extensively in swimmers and in cyclists, just like we see on the left side. This was, I thought, scary data when I read this. Half of men who are elite level athletes will have minor and or major criteria. A third of men and 14% of women will meet major criteria for right ventricular cardiomyopathy. But it's important they won't have the regional akinesia, the dyskinesis, the aneurysms that you typically need for ARVC criteria. And then you're often going to correlate this back to what the ECGs found. Much like we saw on the left side, the RV function is typically normal. So it depends on which athlete we're talking about. Dilated, not dilated, man, woman, what sport they play, LV and RV, they can both be involved. Now, you can also look at coronary arteries. So here's an echo showing you, hopefully what you're seeing is a big coronary artery. You really ought to put color through there at a lower level to see that you can see flow in those usually slow flowing arteries. Here it is in frozen form, showing that there's clearly flow through that big right coronary artery. And here's one on the left side showing normal flow through that side. And this is good for an evaluation when you find it. It's not enough to exclude anomalous coronary arteries in those who you suspect may have it. They have symptoms, they've passed out, or they have chest pain when they exercise. Still remember the MRI and CT are the gold standard for that. But echo will play a role in the ability to identify anomalous coronaries. Aortic size is important. Usually this is done by echo as a screening tool. Make sure that you can actually measure it. I'm showing you here in this yellow box. Many times the sonographers will give me that, and I'll have to send them back and say, shift up a space or out a little bit. Give me a different angle to look at the dilated aorta, because looking at the aorta is an important thing you can't get from an ECG, and you definitely don't have symptoms in the majority of folks who have mild or moderately dilated aortas. So aortic root size also has a cutoff, just like we saw with LV wall thickness. If the aortic root and ascending aorta are above 40 millimeters, that's pathologic. So over 4 centimeters or 40 millimeters for men, 3.4 centimeters or 34 millimeters for women, and anything over 42 is considered a dilated aorta, whether they're a strength athlete or an endurance athlete. And how you measure that sort of depends on your level of comfort and your expertise, but there is some correlation between inner and outer measurements. So for the imagers who are listening, make sure that you're describing exactly where you measured it. And leading to leading is the convention on echo, and it correlates to inner diameters on CT and MRI. Sinus to sinus diameter were larger when compared to commissural diameters, and measuring sinus to sinus from inner wall to inner wall on CT and MRI for root seem to have the best correlation for transthoracic echo. So I love it when the imager tells me where they measured, how they measured it during a phase. If they're able to tell me that systole or diastole, it saves me a step in making sure that I know exactly where they're going to measure. Diastolic function is still important. If you see significant diastolic dysfunction, this favors pathology, but normal doesn't necessarily exclude HCM. This is a paper from Shake over a decade ago looking at athletes with known hypertrophic cardiomyopathy, but they continued to run, they continued to exercise. There was no single parameter that got you off the hook. And enlargement of the left ventricle cavity and normal indices of diastolic function, they don't necessarily exclude HCM. In fact, about 2/3 at an E prime velocity over 9, 90% over 9 in the lateral wall, and normal filling pressures, E to E prime, were present in nearly all of them. That's how they're continuing to exercise, of course, if they have HCM. So normal diastology depends on their age, depends on who they are, what sport they play, but just the cutoff of using 9 or 10 is not enough. For Major League Soccer and for the NHL, we actually use 12 and above for an for a septal E prime velocity, because we think that's enough to clearly exclude those with pathology or not. Strain imaging can help. Of course, you're looking for that normal watermelon, and when you see it, septal variant or apical HCM, that's helpful. Apical sparing certainly is helpful to think about amyloid in that older athlete. But as you know, this is not only present in amyloid. You can see this in other forms of cardiac disease. So it's not just a 2D echo looking at wall thickness. It's tissue Doppler, coronaries, aorta, strain imaging, really a comprehensive assessment that's required as a screening tool using echo. Cardiac MRI plays an important role more and more. The edema, the fat, and the late gadolinium enhancement assessment is really what separates it, in my opinion, from echo. But you can certainly have benefits in terms of improvement of wall thickness. We're learning more about this from James Moon, but we've known for years that there are specific areas where echo just doesn't see things well. The apex, the interventricular septum in the inferior wall, the posterior wall, basal anterolateral free wall, and in those who have non-contiguous LVH. It's just an advantage of cross-sectional imaging, because MRI can look for volumes, ejection fraction, stroke volume, and wall thickness better than any other technique we have. It is the most reproducible imaging technique, so I use a lot of it, looking to see what those ratios are. Typically, there's a 1-to-1 ratio between dilated size for volumes in both the left ventricle and the right ventricle. So the MRI can help you distinguish what often echo has trouble seeing just with your eyes. So it's usually a complementary added value in those who have dilated ventricles in the left or the right, as well as LVH. More and more, we're using tissue characterization, often referred to as the quote virtual biopsy, helping us distinguish between pathologies, right? Lower T1 values for Fabry, a little higher in HCM, and then those really high ones for amyloidosis help separate it. But you can use it for acute myocarditis, iron overload, Fabry cardiomyopathy, and it's an important way to distinguish pathology. You can also use those same T1 maps and ECV to differentiate athletes from HCM. So here's a small study, but an older one from 2016, looking at HCM versus highly trained athletes using this technique where there's a clear separation in that gray zone between 12 and 15 millimeters, where we're struggling. Is this pathologic or not? But there was 100% sensitivity and 90% specificity in diagnosing HCM if the ECG value was 23% or higher. So for the imagers, this is important. When you're looking at a true athlete or not, an ECV under 22% is very powerful in saying this hypertrophy is physiologic and not pathologic. And then expect when you do your late gadolinium enhancement that you're not going to find fibrosis in those under the age of 40. Multiple studies have shown 35, especially under the age of 35, fibrosis is the exception. And when you find it, it's pathologic until proven otherwise. You may find this incidental fibrosis, which is often referred to as kind of like dots and spots that you may find in there from old myocarditis or strain changes related to exercise. These are typically in men between 45 and 65, longer duration of exercise, and usually endurance athletes, these are more common. But when you're doing the fibrosis assessment with LGE, you're looking for either no fibrosis or what we would consider significant fibrosis. Is this arrhythmogenic cardiomyopathy? Is this a dilated cardiomyopathy with old myocarditis? Is this an acute myocarditis? Or is this hypertrophic cardiomyopathy? So significant fibrosis should be a pathologic feature no matter what the age, especially under the age of 35. If you find it, any fibrosis, it's pathologic until proven otherwise. So when you're doing imaging, you're going to do TTEs to exclude, and if you find nothing by TTE in general, you can be done. If you find something that's inconclusive or suggestive, then you're going to use your multimodality imaging approach. And then better yet, if you identify it distinctly, then you're going to confirm it and risk stratify it using cardiac MRI and CT. So we know that these techniques are not going anywhere, that there's athlete screening is here to stay, and that ECG is most often included, echo for those higher risk groups. But what we don't know is when to start, how often, when do we repeat it, and how about an expert review? Who's going to do it? How do you handle it? And what's the goal of it all? If the goal is for safety or disqualification, well, we know it doesn't improve survival, it increases diagnosis. And if it's for disqualification, well, then I'm out. I don't want to disqualify athletes because of our risk or our concern. I want to make a diagnosis, I want to risk assess, and then develop a surveillance plan. Because ultimately, the goal of athlete evaluations is early identification of cardiac conditions to better risk mitigate, to identify a screening strategy for a unique population that serves the community, and then mitigate that risk through individualized, patient-centered care. This should be the goal of all of the screening that we do across the board. And the trouble has been that the guidelines are grossly outdated. This is the original Bethesda, written many years ago, over 25, and then updates here and here and here, but they're outdated. More than a decade old since the last group. Data and scientific advances have clearly changed since then, and we've had a shift in physiologic approach. Since 2015, when it was last published, we've had different international criteria. HRS has changed. Non-sports guidelines like HCM have all been inconsistent with what we said in 2015. The COVID-19 pandemic changed a lot of what we think about how we manage scar and the presence of it. Standard of care for sports cardiology centers opposes much of what we did in 2015. So it led to inequitable outcomes for athletes unable to receive high-level center guidance. And that's what led to the push for the guidance that you saw earlier this year in 2025, published by in both Circulation and JACC, led by Jonathan Kim from Emory as our chair. And these are the sections. So these similar to what we did in the past, but there are three different sections. an ethical aspect of competitive sports eligibility. That's shared decision making. We're going to talk about that. A master's athlete section, which I encourage you to go look at, and additional cardiac conditions and screening considerations were also included. But it started with how we classify sport. Most of us learn this, a dynamic component versus a static component, and what went into all of that. But we know that there's great variation and overlap between these areas, that we changed it considerably. So it's more of a continuum across the athletes for both the endurance and the strength athletes, leading to rowing in that upper right-hand corner. And those of you who've taken care of those athletes, you know they are strong, they are big, and they have endurance like no other athlete that we generally take care of. We also know that bodily collision matters, and we have more folks being placed on anticoagulation for a variety of reasons. So we tried to help gain through our own expertise and experiences what might be a higher risk for bodily collision depending on the sport, and those who are at lower risk who may be able to take full anticoagulation without any added value. This is something different than before. But the real change was shared decision making, our ability to look at the different phases, 1, 2, and 3, and synthesize a different way to approach athletes like we've never done before. So shared decision making is clearly what we do. We've written a lot about this. This is a paper we wrote in 2021 looking at shared decision making in the athlete, because there's evolving science. Things are different than they were 10 years ago. We've learned more about athletes than ever before, and we know that there's some potential harm with removing athletes. The data suggests that totally removing athletes leads to increased psychological stress. You take their friends away, their collaborators, and all of their confidants have now been removed compared to before. What hasn't changed is this model, where the team physician is still the arbiter for all of this, with the athlete and the treating physician contributing using expert consultants and societal guidelines. But what's changed in this is who they are. The sports cardiologist, the disease expert, those have changed and evolved over time, and guidance have to be updated and current. You can't just use your own opinion on this, utilizing what is fully published, and having the team physician you lean on those experts and utilize newer guidelines, so that it's the best interest of the athlete and the school to develop a return to play and exercise plan. So what we wrote about was how to do it in sports cardiology. And what we did was, first and foremost, am I the right person to be doing this? And I have to ask myself this question all the time. If I'm seeing somebody with long QT, or if they've got a defibrillator or prior shock, making sure that I'm the best expert, or should I include someone else as part of the evaluation? Not relinquish it, but engage them in all of that process. Respect the athlete's wishes. All parties should be in agreement. Mom, dad, if necessary, the athlete, and all of the team physicians should be included. We should have the trainers informed and have the athlete engage in their own safety. They should have their own personal AED. We encourage it. We write letters to try and get these paid for, just like you do with somebody with a peanut allergy or asthma. They carry those interventions along with them. They should do the same thing for an AED. And then, of course, document it. Discuss the risk, the potential harm. Even with an AED, there still could be some potential for adverse outcomes. And then plan for surveillance. Is the risk changing over time? It's not a once and done. They've got to see you over and over as the years progress to see if things may change over time. So who makes the final decision? Well, ultimately, the athlete should be at the center, just like the patients are. The team physician should incorporate all input from all the stakeholders across the board, using a risk assessment tool when available, the guidelines and updated societal data, and then create a shared decision-making discussion. These are not quick. These are not short. They are often multiple visits to try and get to a plan where you can develop a safe return to exercise. So I'm getting towards the end here. So let me give you a case. Here's a young woman who is a soccer player. She's asymptomatic, no family history, and she did a pre-participation ECG. Not a diagnostic challenge, right? Clearly abnormal, diffuse ST segment changes and T waves with ST depression. Sent for an echo. No surprise, she has clear HCM, increased wall thickness, no SAM or mitral valve prolapse at rest. We exercised her with and without sprints. We do a unique protocol to try and bring out arrhythmias and obstruction. Normal response, normal monitor, and our MRI confirmed the same, and there's no scar. So the question is, would you let her play or not? And this is really the dilemma, right? She's in front of you saying, I did this ECG thinking it was a good idea, and now I'm left with, is there an added risk or not? Should I have done this? Because HCM is really a dilemma. Low overall mortality. Most of the studies show about a 1% overall risk of your lifetime, but we know that there's a group that is at higher risk than others that can often leave us with a broken heart, like you see here. But in clinical practice, the message has been confusing because we also know that exercise is important in HCM. It's prolonged survival, increased benefit for the patients in terms of their diastology and their ventricular size, and reduction in overall heart failure. So what's happened is that in practice, HCM patients exercise less. They don't meet minimum criteria, and it's worse in the elite and competitive athletes who we've removed from play, and the majority of them do not meet minimum criteria. So in the old days, it was easy, right? When we first started doing this prior to 2015, nobody got to play. It didn't matter what guideline you followed. All competitive sports were essentially excluded. But it's not that simple, right? We know that there's arrhythmic risk in HCM. We know that all of the features you see here contribute to risk, but little by little, we've learned more about the assessment of risk in this group. In 2020, we bumped things a little bit and said, we're going to allow for vigorous and competitive athletics if you've been risk stratified. 2024, we strengthened that by saying recreational vigorous exercise is reasonable and universal restriction is not indicated, and the HRS supported that. And that was based on data like you see here. So this is from Marty Marin looking at almost 2,100 athletes, single center, but almost 5 years of follow-up, and overall risk was about 0.8% for risk for sudden death, over 500 ICDs placed in that cohort, and a very low annual mortality with or without ICD. And those who had interventions, nearly all of them had scar. So using this criteria, we could risk stratify and prevent nearly all sudden death risks with a sensitivity for identifying risk versus no risk or less risk in about 95% of the group. We looked at the absence of scar as an important predictor for outcomes. This is data from both Raymond Chan from Canada and us from a year and a half ago, looking at the absence of scar like we do in CAC scores. And you can see at 2 years, if you have no scar tissue, your risk's about 0.7%. So we know that this group, absence of family history, the absence of hypertrophy, syncope, aneurysms, or extensive scar, they have an absence of risk score. This is a group that I can feel more comfortable with. That exercise echo, I usually add on top of it. I run them looking for arrhythmias and LVOT obstruction, not to disqualify them, but to treat it. If I find it, then I can manage it. This is the group that most of us lose sleep over, the intermediate risk group. The middle group, where you've got wall thickness between 22 and 28 millimeters, 5 to 10% scar. These are the ones that I usually lose a lot of sleep over. And then I got to lean on who they are and do they fit into some of the new evolving data for exercise. Like the Live HCM study shown here, 3 years of follow-up. You can see here over 1,600 athletes of all ages between 8 to 60 years old, average age of about 40, almost 3/4 were over the age of 25. Now we still have a challenge. 9 out of 10 of them were white athletes, and some of them were phenotype negative with a genotype that was positive. But this is the take-home message, that in non-vigorous versus vigorous activity, those who were exercising or not, there was overlap between cardiovascular events. Virtually no difference between events in those who exercise and those who didn't. We looked at elite level athletes then after that. Well, we considered elite as Division I or professional athletes, and they were in that complicated higher risk group that we used to disqualify altogether. Nearly 3/4 of them were initially told they couldn't play, and not all of them chose to return to play. Most of them were able to do so after being risk stratified. So this take-home message is about 4% of them, even at this elite level, still chose to continue to stop playing sport, and there were no deaths in this group. So the overall group is somewhat small, 76, but the ages are much younger than we've seen before, and over a third of them were self-described Black athletes, and over half had hypertrophic cardiomyopathy. So what we took home from this was that the conclusion is that after expert risk stratification and shared decision making, even in these elite level athletes, they may be able to return to play. But keep in mind that risk stratification is just part of it. Screening is just part of it. All of it has to be incorporated. Because if you look at the high profile events like you see here, Christian Eriksen and Keontae, DeMar, and even Bronny, these were individuals that went under screening every single year and they still ended up with cardiac arrest. So we still have to be mindful in this group to have an exercise prescription, what's safe for them, remind them about safe strategies. These are both free documents that we wrote a few years ago for those taking care of athletes to help describe who should play, who should not play, when to worry, and how to describe an exercise prescription for those in HCM. And then finally, I think we finally got it right in this most recent data in 2025. The contemporary guidance is no uniform disqualification. So the days of telling everybody they're out are over. Treat those who have increased risk, guideline-directed therapies if you find someone at risk, but everyone deserves an exercise prescription regardless of their cardiomyopathy. Some will be elite, some will be moderate, some will be less, but having that discussion is important, and shared decision making is a big part of how we evaluate these athletes. So cardiac care of the athlete, in conclusion, is really a team. The sports cardiologist is firmly part of that, understanding the athlete adaptations, the ECG screening, the changes you see in both EKG and in cardiac imaging with echo and MRI, understanding and being part of the evolving data, and using shared decision making. So the risk hasn't changed, but how we identify and how we approach that risk clearly has. But the risk will never be zero, so you still have to have an emergency action plan in AEDs. But there's still more work to be done. And we're actually doing this now. There's an ORCA registry with over 500 athletes we're including. If you have athletes and you'd like to enroll them, please consider them signing up for this. All we need is their permission to use their paperwork, their consultation with you or whoever they see to make sure that they can be included in the study. We just want to follow to see how they do, how they're managed. Did they quit? Did they not quit? What were their decisions and what were their risks over time? Thanks for your attention. I'm hopeful that you have some questions for me. Thanks for the invitation. I'm looking forward to the next stage.
Fantastic, Matt. That was amazing. And you made it sound simple, but it's so complex, and it brings in actually the need for us to organize in several tiers of expertise to be able to sort out these kind of complex issues. Let me start off, and I'm sure that other people are also having other questions. So, I mean, we spoke today about the prescription for the exercise and whether or not to exercise or not. But I believe that you encounter also a significant challenge with the overall lifestyle that people end up choosing, because it's not just exercise, it's also the kind of substance abuse issues or the diets, indiscretions, and other things that contribute to all these phenotypes that emerge. I believe when I was in Mayo Clinic, if you would remember that we had that study on NFL players with a higher risks of um, secondary cardiovascular diseases that emerge later on in their lives. I mean, it's just a continuum. I think if we are focusing on them at one time point but on their lifespans, uh, their entire lifestyle makes a deeper impact. So what are your thoughts
100%.
about
So,
that?
I mean, to that end, I think it's the assessment, it's the management while they're playing, and then many of the football players will come see me within a year or so of retiring and saying, what can I do here to make myself more longevity than my colleagues? And to your point, right? They have sleep apnea,
Yes.
untreated high blood pressure. being 6'6" and 380 makes for a really, or 300 makes you a really good NFL offensive lineman, but it means you're not going to live very long. So they have to do something for that. I couldn't agree with you more. A lot of times especially the coaches are poor models for this, right? They're smokers, they're eating terrible food, they're not really maintaining their other lifestyles, which just confounds the risk in all of them on top of these cardiomyopathies. And then you didn't ask it, but I'll bring it up. There are performance enhancing drugs that are
Yes.
certainly part of this lifestyle, right? We stopped asking them if they're using performance enhancing drugs. I'm not suggesting that they all are, but it's such a canned answer that we don't ask. And the NFL tests for this anyway. So
Yeah, because we
agreed.
get focused upon HCM, but all of these are also contributing to the phenotypes, right? So sometimes there's gray zones that are ending up happening and you receive them, may be related to. So I was just pointing out. And the second question, and then I will, you mentioned about the false positives. Have you ever
Yeah.
thought about maybe on the field having a point of care ultrasound, quick one shot picture to be able to reduce the number of the false positives even before they come up?
Yeah, I think it's important. And I think part of the benefit of the point of care ultrasound will also be because there's some anxiety with this, right? You tell them, your ECG is abnormal. Then they go out and they talk to their buddies, and it turns out they're the only ones who were abnormal. And so not only are they worried about their contract, but now we've alerted them that they may have an increased risk of this. So we often, because of the pro sports, we have an echo on the spot, so they don't need to go anywhere but like
Yeah.
across the hallway. So we sort this out for them very quickly. But in high school athletes, I think a point of care ultrasound may be valuable to at least say, I can't guarantee you still need a full echo, but there's really nothing here that's sinister. The ventricle size looks okay. The wall thickness looks probably normal. It's not 40 millimeters. Maybe we ought to get an echo tonight, kind of thing, right?
Great. I think Kamu has a chat. I'm not sure if you can see. I'll try to read
Yeah.
it out. I was quite involved with testing for NBA combined for 10 years. All of them had HNP labs, ECG stress echo with full Doppler, and those that needed either CCT or CMR right away. Majority of the athletes had some sort of ECG abnormalities. One thing was fascinating was abnormal TDI in those who had abnormal outcomes, granted only over 10 years. Should we be looking at TDI strain in athletes? Also, what are your thoughts about increased incidence of CAD in marathon runners? Why do they have more CAC and CAD? My last, is that the elite baseball players was involved with two teams have least abnormalities? Why is this? So lots of interesting questions there.
Yeah, great questions. A lot to unpack there. So let me do the first one. That you're
Yeah.
right. The NBA should be doing this. They're actually now doing in the last this year and I think the year before they did a diastolic stress test. So at the end of the stress test, they've now added on diastology to see what that looks like because we need to learn more about this. For the NBA now, we're doing routine RV work. We're doing RV strain and LV strain in all of them over the last few years because of all the things you just mentioned. It's not buyer beware anymore. We're not looking to disqualify somebody. Now we're looking to identify things that we can manage and treat and re-stratify. Now that we've crossed that bridge of can they play, now it's, well, can they play safely? Do we need a plan? Do they need a defibrillator? So it's a little more. We've spent the last 10 years getting athletes to trust us that we weren't disqualifying them. When I first started this, nobody wanted to talk with me. The athletes were, you're the last guy I want to talk to, man. Like if my knee hurts, I can at least fake it. If my heart's abnormal, they're going to disqualify me. So now we've gotten to the point where they trust us that we're looking to try and create better scenarios. So yes, we should be doing tissue Doppler. I would argue pre and post exercise and strain in all of those athletes. Not only so we can look for abnormalities, but we can learn more about it, right?
Mhm.
Is there a difference between the center and the point guard? Probably for the NBA. So more to come from that. And as you know, the athlete doing research on athletes is challenging. They don't love it when you report things because they're still afraid it's going to affect their contract.
Mm.
Afraid it's going to affect their finances. So we have to tread lightly on this, but we are chipping away at the ice on this. The second question is about coronary disease in marathon runners, and I love it because this comes up a lot. And the dirty little secret about the sports cardiologist is that there's a lot of excitement for that elite level athlete, but the majority of who we see is the 40 to 60-year-old, 65-year-old who says, All right, Doc, look, I started running a few years ago. I may be a marathon runner now, but I wasn't when I was 20 or 30. And what do I look like? And I think some of the CAC story is that these are many of the athletes are the sins from their 20s and 30s have chased them down. They smoked a little, they overate, they were out of shape, and the CAC probably started, the coronary atherosclerosis probably built up there, and now they're calcifying it. Number one. Number two, if you look at the data on that, still about 60% of the runners, 50% of the runners have CAC scores of zero. So it's still protective. The majority are CAC score zero. And the ones that don't, I think they fall into the other category I just mentioned. And there's still a group of us that think that exercise may act like statins and stabilize those plaques through the benefits of exercising, that it may be somewhat of an anti-inflammatory, a benefit to those coronaries. And the way the coronaries fix themselves is by putting calcification down so that they're less likely to rupture. That could be the other mechanism. Others have proposed that there's shear forces on the coronaries, that all of those extra beats may lead to that. There's still more work to be done for sure, but a fascinating time. And what I don't love about coronary calcium scoring in athletes is that I don't want to give people another reason not to exercise. I don't want them to think that they're harming themselves with exercise. There's a mountain of data for safety and a little bit of data that suggests there may be added risk. And the
And
final one,
you go
sorry,
ahead.
the final one's about the elite baseball players, and you're
Yes.
about to see that data published. So we did the MLB Combine, and you are correct. They don't have a lot of changes. And I was a college baseball player, and what I'll tell you is that we didn't run very much. We're not in the same sort of sport. It's not the same level of sport. It's what I would argue is a skill sport, right? It's a different type of sport compared to being an endurance athlete, where you're clearly more athletic. If you're a CrossFitter, it's different than the other sports and doesn't generate the physiologic adaptations that you typically see.
And just related to an important question when we were talking about coronary artery disease, I also seen that we have this 5K runs and marathons and people they all want to participate, but if there is no adequate preparation,
Yeah,
you don't acclimatize your body to that kind of stress. And you
totally.
said there is some data that you can really create stunning of your myocardium.
Yeah,
And if you have not done your work before that, the preparatory work. So there is some data of you can really create a stress and scars and troponin release,
totally.
not really doing. So I
Yeah.
think this is also something people do not know of. I mean, they say, I'm going to just go for a 5K run or a marathon, and you have not prepared for it, and you put yourself at risk.
Yeah, it's actually really important. And what I encourage athletes is that at least go to your doctor before you run the marathon. Don't do it 2 days before, right? Do it a month before. So we at least have a chance that there may be value in a pre-race clinic for folks who are running for this reason. If you look at the racer data, racer one and racer two, most of them had fixed coronary stenosis. So they weren't ruptured plaques, right? These were fixed disease that if we had seen them beforehand, we may have been able to identify it. So just because you run, just because you cycle, doesn't mean you're bulletproof, and that you can't outrun your genes. So there's still a way to sort through those athletes if we can create a way to get those athletes in to see us.
Beautiful. And there is a question from Sasha, one of our
Yeah.
Echo readers, at faculty members, Sasha East. Excellent talk, Dr. Martinez. For your athletes who develop acute pericarditis, do you get a cardiac MRI automatically to rule out myocarditis, or do you forgo if echo and biomarkers are normal? Secondly, is there a role for biomarkers in general screening?
Yeah, so two great questions. So, in full disclosure, I'm an MRI reader, so I'm biased. I think that you should get an MRI on everybody with myocarditis and pericarditis for a couple reasons. It'll tell us how acute it is. You can tell the difference between big time edema and subacute, and that tells me in terms of timing. The new guidelines actually incorporate MRI, and again, full disclosure, I wrote this section, but using an MRI at initial diagnosis, and then again at 6 weeks. If edema is resolved and the patient has no symptoms and the biomarkers have normalized, you can return them to play at 6 weeks compared to the old days of 3 to 6 months. And that's data from the Big Ten registry during COVID. So I'm a fan of evaluating for myocarditis and or pericarditis at the same time to make sure that you get it right. The biomarkers have value in that group. In general, biomarkers for screening have not been helpful. The troponin, as you know, goes up for everything. The proBNP can go up for everything, especially in women. You may end up having smaller hearts, and the risk for proBNP may be too high, and you may end up finding stuff you wish you hadn't found. So in general, we don't screen for it. But if you suspect pericarditis or myocarditis, then yes, troponin, maybe a proBNP and an MRI, and then look for symptoms. And then once that resolves, then you can risk stratify them further with a treadmill exercise test and usually get them back to playing within a couple of months.
Matt,
Fabulous. I know this
I'm
one.
sorry, this
Yeah.
is Kamal. Matt, I just wanted to put this out there. By the way, thank you. It is so fascinating. I can listen to you lecture the whole day.
Thank you.
Um,
Good stuff, right? It's amazing how the field's evolved, right? Since you and I started, it's amazing where things have started.
so one of the things that I always get into huge arguments about is with the college football coaches. Because when I'm starting an 18 to 20-year-old on antihypertensive therapy, it completely breaks my heart.
Yeah,
And I keep telling them, you need to cut out the salt, you need to lose weight. And the coaches, in no uncertain terms, tell me, no, we are very sorry. These kids have to gain another 20 pounds.
yeah.
And I almost feel like telling them, you guys can gain that weight and take all these antihypertensives. So, how do you deal with this?
Yeah, it's very difficult. And to your point, I mean, some of the athletes are honest with me in the room quietly, and I say, "How do you feel?" And they say, "Terrible. Like this is miserable. I have to. I added 60 pounds in the last 12 months, and I'm miserable." And it is a bit of a challenge that the gladiators that we're creating, they have long-term consequences. And I wish that there was something done as the athlete leaves to better educate them about what's going to happen if they don't lose 100 pounds, if they don't start to exercise. They can't keep eating 10,000 calories a day and expect to do well over time. And I agree, it does break my heart that we're starting them on therapy. And of course, half the NFL athletes are wearing sleep apnea
Yeah.
masks, and
Yes.
it is not a trivial matter in any way. And you're right, as I said, the coaches are horrific models in this. They are. They are not good models. They are driving them in the wrong direction. And of course, they're all eating McDonald's on the bus ride on the way home. And you know, I have four boys that played college sports, and I tried to educate them ahead of time. When they stop for McDonald's, do not do that. Go next door and try and get something that was actually made that day, and I'll pay for it because they eat poorly when they're traveling. It's getting better. The bigger the school, the more nutrition. Much of the Power Fours are getting smarter about this. They're using sort of better tools and nutrition. They're figuring out rehab and sleep and nutrition are a big part of how you're an athlete. And the NBA does a nice job with this. MLS does the same thing now, where we educate them when they come in about money, but we also educate them about nutrition because most of them know nothing and they've gotten there mostly based on genes and luck.
Fantastic. I think we could go forever on this, but I think we have already 10 minutes over the hour. Thank you so much, Matt, for joining, and we look forward to continuing our collaborations and learning from you.
Yeah, thanks for the invite. Super stuff. I look forward to more. Absolutely. Thanks for the invite for tonight.
Great. Thank you.
Good night,
Bye-bye. Bye,
everybody.
everyone.